Awesome. So good morning, people. We are really excited and delighted today to have Parker Gregg from Baylor in Houston present to us on her research in oxygen delivery, iron, and fatigue in kidney disease. Dr. Gregg did her training in Vanderbilt, med school in Vanderbilt, residency at UWash, and then came back to Texas to finish her fellowship. She was faculty at UT Southwestern for a few years. Until then, she moved back to Baylor, where she's on faculty. Her research is around fatigue and depression in chronic kidney disease, among many other things. Take it from here.
All right. Well, thank you so much for having me. I'm really excited to be here. Let's see. I do have a couple of disclosures. So, my research funding comes from the U.S. Department of Veterans Affairs, Calliditas Therapeutics, and the Texas Health Resources Foundation. And I did serve as an editorial fellow for the Journal of the American Society of Nephrology. Um, so, has anyone ever had a patient come into their clinic and tell you something along the lines of, I'm just so tired, right? So, for me, this is all the time. I'd say at least once a clinic this happens. And that's just the people who feel bad enough to say something about it. When our patients tell us this, it's different than the sort of fatigue that many of us might feel after a long day, right? This can be a profound and debilitating form of fatigue that can have a major impact on their ability to function or participate in their life activities. And, just so you know, there's a little bit of controversy around this word fatigue. So, it's the word that I'll be using today. It is the word that we are currently using to describe this phenomenon. But some people who experience this really don't like this word because it doesn't capture how horrible this is for them. And it can be really stigmatizing. And I personally would also argue that it doesn't capture what they mean. So this word fatigue, if we're just asking people, hey, are you tired? Or what does that mean? That could mean that they could have physical symptoms like sleepiness, muscle weakness, fatigability, exertional dyspnea or pain, or it could also mean psychological symptoms, things like depression or even cognitive impairment. So as of right now, this is still the word we're using, but I just want you to be aware that this is something that's currently being discussed and maybe subject to change in the future. So, what I want to talk about today, this has sort of become a little bit of a jack of all trades, master of none kind of talk. So, I wanted there to be at least something in here for everybody. So, some of it is more clinically oriented, things about epidemiology and measurement and how to handle the situation when you're in clinic. And then there's some other bits of it that are more oriented towards physiology, and some things are more geared towards trainees who might, like some sort of, basic physiology. So there's a little bit of something in here for everyone, and I hope that everybody feels like they learned something from it. So let's start with epidemiology and measurement. Um, Several studies have reported fatigue on self-reported questionnaires and found that among people with CKD, about 2/3 to 3/4 report some degree of fatigue. So in this figure, the gray bars show you fatigue that was reported without specifying the severity, and the blue bars are showing you in light blue fatigue that was categorized as mild to moderate, and dark blue represents severe fatigue. So as much as 24% of reported fatigue may be this severe debilitating form of fatigue. So this is a very common phenomenon. And I think, a lot of people ask me about post-dialysis fatigue, and post-dialysis fatigue is kind of interesting in the sense that we don't know for sure whether this is more of a component of a more chronic cumulative experience of fatigue, or if this is something that is caused more by the like physiologic shifts that occur during a dialysis treatment. My personal take on this is I don't see why it could be both, right? So on the one hand, people who have a more cumulative experience of fatigue might just have low reserve to handle the physiologic demands of a dialysis treatment, whereas we also do a lot of things to a person's cardiovascular system and their tonicity and all of these things that happen during a dialysis treatment, such that it makes sense to me that there could be reasons why both of those ways of thinking about post-dialysis fatigue might be correct. But in any case, I think anecdotally, we would probably all say that most of our patients that we take care of who receive dialysis feel bad during and after the dialysis treatment, and the data support that that's true as well. That more than half experience some degree of post dialysis fatigue. And, in addition to the importance of fatigue itself and its impact on our patients' lives, the people who experience fatigue are also more likely to experience adverse clinical outcomes. So this figure is from a prospective cohort study showing that among people with CKD stages 2 to 5, fatigue reported at baseline was associated with higher rates of the composite of death, dialysis initiation, or hospitalization within 1 year. Other studies have looked at the relationship between post-dialysis fatigue and adverse clinical events, and they found that for every hour of increased time to recovery, which is kind of a proxy for post-dialysis fatigue, so every hour of increased time to recovery is associated with a 3% higher risk of hospitalization and a 5% higher risk of death. Now, how we measure fatigue depends really entirely on the context that you're in. So, what you might be looking for in a measure depends on what you need it for. In the clinical context, when you have patients who are, potentially overburdened by all we're asking them to do, you might want something that's more short and simple, that's very easy to administer, and particularly that reflects its impact on their life and their ability to participate in their life. Frequently, we try to obtain measures of fatigue while obtaining information about other important symptoms like pain, cramps, etc. There are lots of things that we need to ask our patients about, and incorporating fatigue into that makes a good deal of sense. But in the research context, you might want something a little bit different. So, you might want a little bit of a longer and more complex measure that is specifically designed to measure fatigue rather than being a single item from other sources. And ideally, it would be a measure that captures multiple dimensions of fatigue. So it might be able to distinguish between the more physical symptoms versus the psychological symptoms like depression. And ideally, it'd be associated with adverse clinical outcomes just because that's an important thing. But all of the measures that we have are basically Likert scales. So, there are all these subjective scales that give you a range of, I'm not fatigued at all, I'm extremely fatigued, and that's the one consistent thing between all the measures that we have. So every measure that we have, every way that we have to measure this is this subjective way. There's not a more objective way to get at this, and I would argue that the subjectivity of it is actually an important thing because when we're trying to ideally what we're trying to do is help people feel better. And in that case, the outcome that matters most is their subjective experience, right? So in a way, I think that that's actually a strength here. The Standardized Outcomes in Nephrology group did develop a measure a few years ago to be used for people on dialysis that is a simple 3-question Likert scale measure. And it is very easy to administer. It's simple. It's quick. This is really more geared towards the clinical context. So thinking about like in whom you would use this, it's a way of asking people, hey, do you feel tired? And it gets at that third question is getting at that question of how does this impact your participation in your life? So this one is probably the more commonly used one in the clinical setting. But in the research setting, there's actually really no consensus on what measurement tool to use. So there are several studies that take the fatigue item out of other questionnaires that are meant for other things. So for example, I'm not going to go through what all these abbreviations mean. That's not what I'm trying to do here. But basically, like the QIDS and the BDI are 2 depression screening tools that have a question about fatigue because that's an important depressive symptom. And so some studies it would just pull that fatigue item out of those questionnaires. Or the SF-12 is a quality of life screening questionnaire where you can pull the fatigue item out of there. One of the more commonly used ones is from the SF-36, which takes 4 items out of a quality of life questionnaire and gives you a subscale for vitality, which is used to represent fatigue. And then probably the most commonly used one in clinical trials is the FACIT fatigue, which is a 13-item questionnaire and gets at some of these dimensions of fatigue in a little bit more detail. But overall, there are just some general problems with measurement. So, first of all, most of them don't distinguish between individual symptoms. These items are basically saying, hey, are you tired? And they're not getting at this question of what that means, right? Are people dyspneic? Are they in pain? Are they having depression or what? They don't distinguish typically when the fatigue is happening. So this concept of distinguishing post-dialysis fatigue from a more chronic cumulative experience of fatigue is something that's not really directly assessed with the measures that we have available for the most part. And there's just really no consensus on what measure to use overall. So just a couple of key points that I want you to take away from these basic concepts of the epidemiology and measurement of fatigue is that fatigue can mean a lot of different things, and it can mean different things to different people. That most people with kidney disease report fatigue, and many of them have these very severe symptoms that are highly impactful on their life. That fatigue is associated with adverse clinical outcomes, and that what measure you use depends entirely on the context that you're in. So there's not really like a simple answer to what you would use. So at this point, I would like to pivot a little bit and talk about why people experience fatigue. And in this case, I'm not planning to be exhaustive about a lot of the different ways. This is a highly multifactorial problem, but I want to focus on is issues related to oxygen delivery because I think it's very interesting. And I will just put a cautionary note up for a moment that I'm weaving together a story from strings here. Some of these studies are very small. These are not necessarily data that come from large randomized trial for the most part. But I think that there is a story to be told here. And so I hope that I can convince you of that. So first, let's establish that people with CKD report higher levels of fatigue even at low levels of exertion. So this particular study enrolled 13 people with CKD stages 3B to 4 and 13 healthy controls who were matched for age, sex, height, body mass and composition, and physical activity level. And on the x-axis, you see different levels of activity intensity measured in METs that they achieved by cycle ergometer exercise as part of this study. Now, the METs reported here are equivalent to activities such as ironing, food shopping, and putting away household items. And on the y-axis is perceived exertion. So even at these relatively low levels of activity, the people with CKD consistently were reporting higher levels of perceived exertion compared to the healthy controls. And they also developed higher blood lactate levels, even at these low levels of activity. So for levels of activity as strenuous as food shopping or putting away household items, the people with CKD had higher blood lactate levels, even exceeding 2 millimoles per liter. And it turns out that the people with CKD also had lower levels of whole body oxygen delivery during exertion. So this value was calculated from the cardiac output, which was measured using thoracic bioimpedance, that thoracic bioimpedance is a tool I use in my own research as well. And I'd be happy to answer questions about that later if you have them. But in any case, that's a tool that can be used to measure cardiac output in real time in a non-invasive way. So they use the cardiac output, the hemoglobin, and the oxygen saturation to calculate this whole body oxygen delivery. And the differences that they found here were mostly driven by the hemoglobin levels, which were on average 13 in the CKD group and about 15 in the control group. But they noticed that people with the CKD failed to increase oxygen extraction in this context, as measured by both infrared spectroscopy and oxygen extraction ratio. And they also found no difference between groups in heart rate, stroke volume, or cardiac output, which might be appropriate and expected responses to compensate for low hemoglobin and maintain oxygen delivery. So all of this combined is to say that the people with CKD had many reasons related to oxygen delivery and extraction that may be maybe contributing to this relying on anaerobic glycolysis, like developing a little bit of a lactic acidosis and maybe contributing to this experience of exertional fatigue. So to put this in general terms, ultimately, problems with getting oxygen delivered to where it needs to be in the exercising skeletal muscle is probably a significant contributor to a person's experience of fatigue, particularly exertional fatigue. And this would include alterations in oxygen transport from the lungs to the skeletal muscle capillaries, which is called oxygen convection, the movement of oxygen from the intravascular to the intracellular space, which is called oxygen conductance, and oxygen utilization in mitochondria. So I would like to use this framework to get a little bit deeper into each of these concepts. So let's start out with anemia. which is the one that we're probably the most familiar with because we think about this every day in our clinical practice. So I'm not going to get into, observational associations of anemia with fatigue. I mean, that's very well known both in the kidney literature and in other populations, but jumping straight into some clinical trial data that we have. So the treatment of anemia is actually probably the area where we have the most robust trial data supporting an intervention. You probably are, quite comfortable with this concept that the treatment of anemia with erythropoiesis stimulating agents, or ESAs, may help fatigue in some cases, right? That's been in the guidelines for years. And you're probably familiar with the results of CREATE and TREAT, which showed that the management of anemia with ESAs led to a modest but statistically significant improvement in patient-reported fatigue. So on the left, I'm showing you results from the CREATE trial, showing that a higher hemoglobin target led to improvement in fatigue compared to a lower hemoglobin target. And on the right, I'm showing you results from TREAT, in which the darbepoetin group achieved a higher hemoglobin level and had greater improvement in fatigue over the course of the trial. So, conclusion made, right? We have a statistically significant difference here. So like we're done. Hypothesis tested, conclusion made, this helps fatigue, right? And maybe, right? Maybe, but maybe only a little bit. So when looking at these data, the thing you have to take into consideration here is that even though these results were statistically significant, neither one really met the generally accepted thresholds for what would be considered clinically significant for these measures used. So they might help a little bit, but this is not solving the problem. And more recently, the HIF-PHI daprodustat has also been shown to modestly improve fatigue compared to placebo. So here, I'm showing you the fatigue levels on the y-axis with the daprodustat group shown in orange and the placebo group shown in blue. And you can see that as early as 8 weeks after randomization and persisting to 28 weeks, the daprodustat group had a greater improvement in fatigue scores as measured by the short form 36. So the clinically significant difference for this measure is 5 to 10 points. So this trial actually was getting into that range that might be considered clinically significant. And when thinking about why this might be, just a brief oversimplified overview of HIF. So in settings of abundant oxygen, HIF alpha gets ubiquitinated and degraded. However, under circumstances of low intracellular oxygen availability, HIF alpha translocates to the nucleus, proliferates, and binds to coactivators and leads to increased transcription of hypoxia responsive genes, which includes genes pertinent to iron metabolism, angiogenesis, and mitochondrial genesis, just to name a few that are pertinent to our conversation today. So given that HIF alpha has these multiple downstream effects on other factors, it's certainly possible that it could contribute to why there might be this slightly greater change in fatigue compared to trials of ESAs, although some more head-to-head comparisons in other studies, this difference wasn't significant on fatigue. So let's move on to cardiovascular disease. Now, earlier I mentioned that people with CKD did not have a compensatory increase in cardiac output to increase total oxygen delivery in the setting of lower hemoglobin levels. And it's certainly possible that underlying cardiovascular disease may be playing a role here. So let's dig into some of the data showing relationships between cardiovascular disease and fatigue and physical functioning. In this particular study, among people with an EGFR between 25 and 60, they showed that impaired global longitudinal strain, or GLS, which is an echocardiographic measure of left ventricular systolic function, was associated with the 6-minute walk test, which is a common measure of functional capacity. And here is this relationship shown as a scatter plot. So obviously there's a lot of variability here, which is to be expected for something as complex as functional capacity. But even so, there were significant correlations between systolic function as measured by the GLS with the 6-minute walk test. And they also found that impaired GLS was significantly associated with worse patient-reported fatigue, right? So the subjective experience of fatigue, which is a different concept than their physical functioning. Now, when it comes to post-dialysis fatigue, the cardiovascular effects of the dialysis treatment may also be playing a role here. So they're shown in orange, including ultrafiltration volume, intradialytic hypotension, and intradialytic cardiac ischemia, among other factors, could be related to this experience of post-dialysis fatigue. So I think many of us have heard our patients tell us that how much ultrafiltration they get or the rate of ultrafiltration that they get might make them feel worse after dialysis, right? I feel like I hear this all the time. And there are some data to support this. So what I'm showing you here is from the Dialysis Outcomes and Practice Pattern Study, or DUMPS, which is a large observational study of people on dialysis. And they showed that for every 1% increase in intradialytic weight loss, there was a 4% higher odds of a longer time to recovery after dialysis, this proxy for post-dialysis fatigue. And they also showed that compared to an ultrafiltration rate of 5 to 15 milliliters per minute, that the rate of less than 5 or greater than or equal to 15 were both associated with a lower odds of a longer recovery time. And so that might seem a little bit odd at first, but when interpreting this, you have to remember that these are observational data, not clinical trial data. So the people who can tolerate a higher ultrafiltration rate might be in better cardiovascular health and thus may be less likely to have a longer recovery time, for example. Or people who have a slower ultrafiltration rate might adhere more closely to salt and fluid intake guidance or have more residual kidney function. So there are some reasons to think about that might explain why this relationship was seen the way that it was in DOPS. Another hypothesis is that intradialytic hypotension may be contributing to poor perfusion and thus post-dialysis symptom burden. The data in this area are not quite as clear. They're conflicting. And there's not really a clearly established relationship between intradialytic hypotension and post-dialysis fatigue or post-dialysis recovery time. But there are some studies showing that there may be a signal here. So I'm showing you one in which the intradialytic hypotension was associated with a 3 times higher odds of a longer post-dialysis recovery time. And that was independent of some important covariates, including age, dialysis vintage, ultrafiltration rate, etc. And what about myocardial stunning? So, this is another small but very interesting study in which the gray bars are showing you the number of participants, and the black X's are showing you the proportion of participants who had fatigue. So on the x-axis, we see the change in wall motion abnormality score during the dialysis treatment. And so this study was suggesting a potential relationship between myocardial stunning and a person's experience of fatigue after dialysis. They also, in this same study, did some multivariable analysis and showed that the change in wall motion abnormality score remained associated with post-dialysis fatigue, independent of other important characteristics, including depression, changes in intradialytic blood pressure, and total ultrafiltration volume. So this suggests that underlying cardiovascular disease and perfusion abnormalities associated with that, just the physical stress of a dialysis treatment, may be related to this feeling of exhaustion during and after dialysis. Here, I want to take a little sidebar for a moment and talk about physical activity. Now, obviously, physical activity has a lot of benefits for people beyond cardiovascular disease, right? It can help with muscle strength, depression, and sleep quality, just to name a few. But when we're talking about cardiovascular disease, I felt like this was the place that made the most sense to talk about how we address this. And physical activity is the intervention of choice here. So I've only selected one study to show you here, but there are several small trials showing a benefit of exercise, whether cardiovascular or weight training, on both measures of physical functioning, such as the 6-minute walk test, as well as on patient-reported fatigue severity. Exercise interventions can include things like treadmill walking, stationary bicycle, or supervised weight training. And this has been relatively consistent despite the studies being fairly small. And there are also some data to support that exercise might improve post-dialysis fatigue too. So this is another representative study that looked at post-dialysis fatigue before and after a 9-month intradialytic exercise intervention and showed that the severity and duration of post-dialysis fatigue improved. But this also illustrates some of the really important limitations to think about with this kind of study. So if you look at the values at baseline from before the intervention, trials of exercise interventions generally select for people who aren't that fatigued to begin with, right? So in this case, the mean was less than 2 out of 5 for each of these 3 domains. And it's not clear whether this kind of intervention would be as effective for people who are less likely to want to do it in the first place. That being said, there are so many benefits to increasing physical activity that this is still worth recommending as an intervention that helps with fatigue. And I haven't gone into exactly how I go about recommending that to people here, but if you're interested, we can always talk about that a little bit later. So next, I want to talk a little bit about some of the hypotheses that have been tested about skeletal muscle blood flow. So one hypothesis that is supported by animal studies is that kidney disease promotes microvascular rarefaction, which is reduced blood vessel density in skeletal muscle. So in this study, the authors induced uremia in mice in two different ways, with dietary adenosine and with a 5/6 nephrectomy. And in both of these models, the microvessel density seen in the cremaster muscle was significantly less than in the controls. Now, this relationship is less clear in humans. Of course, this particular study was very small, but it showed that on muscle biopsy, there was no difference between those with CKD and controls in capillary density, capillaries per skeletal muscle fiber, or in capillary basement membrane thickness. So the potential contribution of microvascular rarefaction is less clear here, but certainly a possible contributor to this phenomenon. However, there may be some important differences in capillary vasodilation that could impact total blood flow and therefore oxygenation. So there are data to support this in animal models as well, but what I'm showing you here is human data. This particular study looked at the vasodilatory effects of insulin in lean and obese people, and they showed that among lean people, skeletal muscle vasodilation in response to insulin led to a 200% increase in blood flow, which was not seen when administered the non-insulin control. But this same relationship was not seen in the people with obesity. So this phenomenon has also been shown to decrease skeletal muscle glucose uptake. So, given that insulin-resistant states such as obesity and diabetes are frequent causes of kidney disease, it's likely, and I think, altogether possible that this could be contributing to the overall pathophysiology of decreased total oxygen delivery to skeletal muscle and other tissues, and probably also, therefore, fatigue. In addition to these mechanisms that we've discussed that decrease delivery of oxygen from the lungs out to the tissues, reduced oxygen extraction from the bloodstream into the intracellular space may also be contributing to poor total oxygen delivery. And we've actually known this for decades. So this is a study from the 90s in which they looked at people with kidney failure on hemodialysis who had anemia, and they looked at them before and after receiving erythropoietin. So hemoglobin increased from 7.5 to 12.5 with this intervention, because remember, it was the 90s, right? We didn't know. So they went up to 12.5 on the hemoglobin. And they had patients cycle, and they measured their femoral arterial and venous blood gases and their femoral venous blood flow, and used this information to calculate the oxygen delivery and uptake. So although the hemoglobin increased by almost 70%, the peak oxygen uptake only increased by about 33%, and oxygen conductance increased just a little bit, as shown here by the slope of this line. But when they compared the people after ESAs to healthy controls, the people with kidney failure on dialysis after ESA were still 33% lower oxygen extraction compared to the control participants. So even when they had their hemoglobin corrected to 12.5, they still were having limited maximal oxygen extraction. Now, more recently, we can measure oxygen extraction with a little bit less fuss using non-invasive near-infrared spectroscopy. So the values I'm showing you here are tissue oxygenation saturation indices, which is basically the proportion of hemoglobin that's oxygenated. And this table shows that about 63 to 64% of hemoglobin is oxygenated in people with and without CKD at rest. But with exercise, the non-CKD group extracted more oxygen and achieved a saturation index of 42, whereas the CKD group had a less strong response and achieved a saturation index of 46. The difference from rest to exercise was 16 for the non-CKD group and 10 for the CKD group, and although this didn't reach statistical significance, it is consistent with the data that I showed you in people with kidney failure and suggests that people with CKD may have a decreased ability to extract oxygen from the blood to use in exercising skeletal muscle. So, whether this is due potentially to fibrosis or microvascular dysfunction or other factors is currently not clear. And finally, I want to talk just a little bit about mitochondrial dysfunction. These studies that I'll tell you about didn't directly measure patient-reported fatigue, so I can't comment on relationships there. But given the importance of oxygen utilization to what we're talking about regarding oxygen delivery and aerobic respiration and lactic acidosis, I think it's still relevant to discuss. So this concept crosses over a little bit into uremic myopathy, which I've not planned to get into a lot of detail today, but briefly, it is known that people with advanced CKD or kidney failure on dialysis have many abnormalities of skeletal muscle, including morphologic abnormalities of mitochondria. And this includes decreased mitochondrial volume density, which is thought to be related to increased mitophagy. And the mitochondria can also be swollen and express markers of increased mitochondrial oxidative stress and dysfunction. Now, this same group from the slide I just showed you also did another study that showed that mitochondrial function was significantly associated with physical performance as measured by the 6-minute walk test. Now, here's another study showing that people with CKD stages 3B to 5 had lower markers of mitochondrial mass and mitochondrial protein content normalized to actin compared to healthy controls. It's worth noting here that the healthy controls were actually about 3 years younger on average. They were 58 compared to 61 years old. But the number of men and women and the number who were described as physically inactive were the same. And the other thing is that there was only one person with diabetes. So diabetes has known effects on mitochondrial function, but that doesn't explain what they're seeing here. They further showed a decrease in transcription factors involved in mitochondrial biogenesis. However, these studies didn't report patient-reported fatigue measures, so we don't have data from this study showing whether that could be related. Now, there was another study that looked, again, another small study looking at mitochondrial markers among young people. So the one I showed you on the previous slide was among older people. This particular study was among people with a mean age of 25. And they actually showed no difference in mitochondrial mass or protein content. And they also showed no difference in important enzymes for oxidative phosphorylation, such as pyruvate, succinate, ascorbate, or mitochondrial respiratory chain complexes. So whether age and multimorbidity associated with CKD might explain some of these relationships remains unclear. But at the end of the day, I would say it's still a knowledge gap, the degree to which mitochondrial dysfunction might be a player in patient-reported fatigue or exercise tolerance. So what I want you to remember about what we've just discussed is that fatigue is complicated. There are a lot of factors that come into play here, and it's at least likely in part related to poor tissue oxygenation of exercising skeletal muscle. Anemia and cardiovascular diseases are features that we're all very familiar with from our clinical practice that contribute to this concept, but there's probably more to it than that. And so although ESAs and exercise may help people's subjective experience of fatigue, they aren't really enough to completely fix this complex problem in a meaningful way on their own. Now I would like to transition toward iron and iron deficiency in people with kidney disease. So why talk about that? Well, we know that in the absence of anemia, iron deficiency is associated with fatigue. We also know, as I'm showing you here, that in the general population, for people with iron deficiency but no anemia, the administration of iron improves patient-reported fatigue. So, given that we know that iron handling is abnormal in people with kidney disease, I think it's worth digging into our understanding about iron handling in kidney disease specifically, as this could certainly be related to the high burden of fatigue in our patients. So just a little bit of a review of this, but as we know, erythropoietin regulates the development of erythrocytes in the bone marrow. And this process requires iron to differentiate erythroblasts into reticulocytes. Now, iron gets absorbed from the GI tract and binds to soluble transferrin. And this then transports iron to the liver and the spleen, where it is stored, or to the bone marrow, where it's used to make red blood cells. And Macrophage phagocytosis of destroyed red blood cells plays an important role in iron recycling. Now, this process is in part regulated by erythropoietin and can be impaired in people with kidney disease. But the other thing that can happen in kidney disease, of course, is that increased hepcidin production in the liver, stimulated likely by increased inflammation, impairs iron absorption from the GI tract and the release of stored iron from the liver and spleen. So the effect of all of this is a combination of an absolute and a functional iron deficiency in people with kidney disease. And the problem is that diagnosing iron deficiency can be really tricky in our patients because of these alterations in the physiology of iron handling and storage, as well as other effects of kidney disease on the biomarkers typically used to identify iron deficiency, so ferritin and transferrin saturation, or TSAT. The interpretation of these lab values, as you know, is very different in people with CKD than in people with healthy kidneys. So this particular study used iron stores seen on bone marrow biopsy as the gold standard to define iron deficiency among people with non-dialysis CKD stages 3 to 5 and a hemoglobin less than 11. And they found that the prevalence of iron deficiency on bone marrow biopsy was 48%, so it was highly prevalent. They looked then at different cutoffs of the biomarkers of iron stores, and generally speaking, they were quite poorly sensitive, if in some cases decently specific. The other issue at play, of course, in our patients is that these biomarkers don't distinguish between the absolute and functional iron deficiency. So unfortunately, we don't really have other useful biomarkers for this. So right now, this is still the best that we have in the clinical setting, shy of getting bone marrow biopsies on people, which of course we're not regularly doing. But it does make it difficult to do large-scale epidemiologic studies of this problem. And we also know from several observational studies that lower biomarkers of iron stores and erythropoietin resistance are associated with patient-reported fatigue in people with kidney disease. So this particular study was among kidney transplant recipients, actually, and found that iron deficiency, which they defined in this case as both a TSAT less than 20 and a ferritin less than 100 micrograms per liter, was associated with severe fatigue, while anemia was actually not associated with fatigue at all, interestingly. And we actually also do have some clinical trial data in this area. So in this trial, it was a randomized trial, but they randomized people with non-dialysis CKD with or without anemia to two different forms of IV iron. They all had iron deficiency at baseline. They all received IV iron, but it was two different formulations. So there was not an untreated control arm to compare to here, but the participants received a dose of IV iron at baseline and another dose at 1 month. And they found that the patient's subjective experience of fatigue, measured both by a visual analog scale, which is effectively like a scale of 0 to 10, and on the SF-36 vitality subscale, improved after that first month of iron administration. And the improvement on the SF-36 vitality subscale was about 15 points, which is what would be considered clinically significant. So just a few take-home points about absolute and functional iron deficiency is that, iron deficiency, even without anemia, may contribute to fatigue. And given that this is so common in our patients, I think that it's common and it's hard to diagnose in our patients. I think it's worth considering to what degree this is affecting how our patients feel. That giving iron may help. Obviously, in people with kidney disease, that can get a little bit complicated with the functional iron deficiency. But I think it's worth at least a trial of iron in people who are feeling this way and have iron deficiency, and that diagnosing this can be very tricky in large measure because the measures are so insensitive. So there may be a lot of people out there who have absolute iron deficiencies that we aren't identifying based on the biomarkers we usually use. So to round this out, I want to put things into a conceptual framework and just bring it back to the clinical setting and tell you what it is that I say to people who come to me in clinic saying that they're having this problem. So this is the conceptual framework. And Basically, anemia, oxygen delivery, and cardiovascular disease are only some among several other interrelated processes that contribute to fatigue in people with kidney disease, right? We haven't gone into all of this today. So things like impaired skeletal muscle function, protein energy wasting, depression, insomnia, these are all factors that are contributing to this cumulative experience of fatigue in our patients. But impaired oxygen, convection, conduction, and utilization probably all contribute to the development of this lactic acidosis with exertion, which is likely an important contributor to a person's subjective experience of fatigue. And management of these individual components with erythropoiesis stimulating agents to raise hemoglobin levels and iron to manage iron deficiency, or other treatments to address other parts of this complex pathophysiology might help the way people feel, but perhaps only a little bit. And I hope that after everything that we've discussed today, it's clear why any single intervention like this is unlikely to make a huge difference in something that has such a complex pathophysiology. Exercise, however, may benefit multiple of these pathways and is, at least at the moment, the intervention that has been the most consistently shown to improve fatigue for people with kidney disease. So when I have a person sitting in my clinic room telling me that they feel just awful, exhausted all the time, aside from getting a better sense from them about what they mean by that, this is what I tell them. So the first thing, and this is actually really important, and I don't think should be understated, is to tell them that this is common. I can't tell you how many times I say this to someone and they look at me just sort of shocked, saying, I thought it was only me, right? It's meaningful to people to know that this is potentially related to their kidney disease and that a lot of other people feel this way. I also tell them up front that this is a complicated problem and that we're not likely to get a clear or simple answer or find a clear or simple treatment that's going to make them feel better, right? That we look for a lot of different things that might be contributing to this feeling and we address what we can, but that it's unlikely that we're going to be able to, let's just change this one thing and all of a sudden they're going to feel better, right? This is just too complicated for that. But, we can look for a lot of contributing factors, and there are some things that we can do to help them, including treating anemia and iron deficiency, and that can at least help them a little bit. But at the end of the day, increasing physical activity is the thing that has been most clearly and consistently shown to actually help people with this problem. And so I actually spend a lot of my time discussing with people what sorts of activities they enjoy and finding ways to incorporate moving their bodies more into their day, just in a way that's enjoyable and sustainable for them so that they might be able to keep it up with consistency. Rather than recommending something to them that's going to be unattainable. I think the consistency is more important. So my focus is generally on moving your body more is better than moving your body less, and how can we incorporate this into their lives in a way that's going to work for them? What goals can we set? Just earlier this week in clinic, the goal we set was that my patient who was feeling this way really wanted to get back to fishing. He really wanted to be able to go fishing again. And so we said, okay, well, what can we do to get you there? And I think that motivation is very important. So thank you so much for your time today. I hope you all feel like you learned something, and I would love to hear your questions, comments, or any feedback that you have for me.
Thank you. Thank you for that really wonderful overview and, dialing down and explaining the studies to us. If people have questions, please raise their hand and unmute themselves. Maybe you could stop sharing so you could see all of us if
Good
you want to do
idea.
that. Yeah.
Yes, absolutely.
Yeah. You had mentioned something about thoracic bioimpedance. If you want to tell us a little bit more about what that is and how it's measured.
Sure. So it's kind of cool. And I really enjoy using these tools in my own research because they're very interesting. So they are completely non-invasive. And, of course, they're not the gold standard. It's not a right heart cath, right? It's not that. But when you're talking about doing research on outpatients, doing something that's completely painless and non-invasive is, generally speaking, much preferable to doing like a right heart cath. So the way that they work is you put stickers on someone's thorax, and it's kind of like an EKG in the sense that it will emit a small painless electrical current and then receive that electrical current. And effectively, what that is doing is watching fluid go in and out of the heart, and calculating that fluid going in and out of the heart. And the machine also connects a blood pressure cuff as well. So it'll use the electrodes, watch fluid as it goes in and out of the thorax, and it can use that information to calculate their stroke volume, their stroke volume variability, their cardiac index, and then using the blood pressure, it will calculate a total peripheral resistance index as well. And so you can get a sense of what these measurements are doing in real time.
Sounds pretty cool. I knew about using it for volume status with legs and hands, but thoracic also sounds cool. Peter.
There we go. Hi. Thanks. The whole iron story. Of course, those EPO RCTs done in the States, they didn't use enough iron. Many people were iron deficient. We've always used lots of iron. And I think that was reinforced when that stuff came out, mostly from heart failure literature about iron making a difference. And the parameters you flashed up really are very restrictive. I think, I'm a ferritin less than 200 or TSAT less than rather than and. I guess since in the last few years, almost everybody's using lots and lots more intravenous iron, and we are too. Is there any sense that that's made any difference to anybody as far as fatigue? Has anybody really looked at it again in a more liberal iron era?
What I was really hoping for to answer this, because I have the same question and I don't have a good answer for you, because I was really hoping that there would have been an analysis of Pivotal looking at this, right? So that would have been great. So the primary publication from Pivotal reported some general quality of life measures, but they didn't specifically look at fatigue. And then I have also seen a secondary analysis looking at baseline quality of life measures, including fatigue, but not as an outcome, right? So where I'm interested in is seeing this as an outcome of the different iron strategies, the proactive versus the reactive iron strategies. But I haven't seen those data out there. I think it's a great question, and I have not seen anything firm that answers it. But I agree with you. I tend to give a lot of iron, and I tend to be a little bit more liberal with my interpretation of the biomarkers as well. I think that it's so hard to diagnose it accurately, and I think the lack of sensitivity is probably a big problem with using those more restrictive thresholds.
Yeah, on the iron, if I can allow, I can ask more. I've seen that literature about fixing ferritins in the non-CKD population, but I've never been convinced. Maybe I should be after what you've shown. We only mostly give iron if people are anemic, IV iron, or heading in that direction. Should we be checking, ferritins even in people with normalish hemoglobins in CKD? And do you then look for an excuse? Ask them, are you feeling tired? Because I see this low ferritin, and give them iron.
Well, maybe it puts the cart before the horse a little bit, right? But if somebody tells you they're feeling tired, I think it's very reasonable to check their iron levels, or their iron biomarkers, I should say, and then act on them even if they're not anemic. I think that'd be a very reasonable thing to do. So my usual strategy is, when someone tells me they're tired, that is among the panel of things that I'm ordering for them, among other tests. Like if they sound like they might have sleep apnea, get that sleep study. And there's all these other things that you might want to do when somebody tells you they're fatigued. But I would say high on my list is to check their basic labs, including their iron biomarkers, and just address what you find.
Right. Again, we still focus a little bit on anemia here. You showed that intriguing analysis from CREATE and TREAT, showing, maybe the higher hemoglobins had some improvement in the fatigue. But on the other hand, we have, and at least locally and with the KDIGO guidelines and all that, we are drifting towards the 9.5 to 10, 11 maybe at the most hemoglobin targets. Is that is that something we should reconsider in some select populations? How can I, the higher hemoglobins are associated with more cardiovascular outcomes, right? So that's not good. You don't want to do that.
No.
But how do you square that circle about fatigue versus CV outcomes?
I've never had a good answer to this question, and I don't know that anybody does. It's a great question, right? I think we would all love some better guidance on this, but for years, the guidelines say, oh, like consider an individualized target for people who feel fatigued. But what does that mean? And in whom do you consider that, and what do you individualize to? I don't think that those are questions that I ever had a good, confident answer to. So I generally am so concerned about the cardiovascular outcomes that I don't usually target a higher hemoglobin specifically unless somebody is really suffering. Um, because I think that there are so many other things that contribute to this problem that I don't know that the risk of the cardiovascular outcomes would outweigh the, potentially incremental benefits specifically to fatigue in the absence of addressing all these other problems that could be contributing to it. So my general way of thinking about this problem is that there is no one single intervention that's going to make a huge difference, because it's just too complicated. If you're doing an intervention and fixing one problem, but there's still 5 others that are going unaddressed, then how much of a dent are you going to make in this problem? So I necessarily think that interventions need to be complex and individualized overall, but when it comes to a hemoglobin target, that's not part of my common practice, I'll say.
Okay, that's good to know. And it's too bad the HIF never took off, inhibitors didn't took off. I think vadadustat is perhaps available in the US, but we don't have any HIF inhibitors available here. Is there anything going on in that area with more research? Because it does look, the physiology looks attractive to see if there's something going on there.
It does, and it has so many downstream effects. Like the concept of it sounds very promising. I have not heard about much specifically going on in the fatigue space with those, although I should ask my boss. Wolfgang Winkelmeyer is my boss, and he's very involved in that space, so I can ask him and let you know.
And last question, if other people don't, I'm monopolizing it a bit here. Is you mentioned something about how would you encourage physical activity, and you talked about the fishing example. But when I tell people, oh, you should exercise or you should do more when they're tired, it's the opposite of what they expect, right? They want some quick fix. Are there any other tips on making people walk or exercise or do stuff when they are actually feeling tired and fatigue and exhausted, which is, I agree with you, it's extremely common, right? I hear that all the time.
All the time. And it's a huge barrier to doing the one thing that seems to help, right? It's a real conundrum. Motivational interviewing works, and focusing on the goals that people have works. So I talk to people in actually a fair amount of detail about the evidence. I think that they like that. And I think that they like hearing that, hey, this is actually like the one thing that really has some decent, if small, but like repeated interventions that have shown to have an effect on this way that you feel. And focusing on what they want to be able to do, and thinking about exercise as a means to get there rather than just like a slog that they need to incorporate into their daily life, even though they don't want to, is a better way to get them interested in saying, okay, if I want to get back to being able to fish, then I need to be able to, walk. And then talking to them about incremental exercise. So I'm not telling them, okay, you got to start going to the gym every day. Like, no, that doesn't work. And that they would just laugh in my face. That would be ridiculous, especially because I take care of an older population in my practice location. So it's all about talking about, how do you spend your day? What are some ways that you might be able to incorporate just a little bit more activity into your day? Do you like to golf? Do you like to walk? Do you like to swim? Like, what do you like to do? And try to figure out if they can get just a little bit more. And as they incrementally increase their exercise tolerance over time, that's what's going to be more likely to help them. So that big focus on consistency and sustainability, I think it's as important as can be.
That sounds useful. The conference room.
Hi, sorry. Thank you for that. Actually, on that note, do you ever, I guess, to try and make patients more accountable, have you done this, actually maybe prescribing them an exercise program or something, or an activity, or you're gonna, let's say, for the next 2 weeks, you're gonna walk 5,000 steps 3 days a week, then you're gonna increase to 4 days a week, prescribe it, and then re-see them just for the purpose of, did you increase your physical activity to kind of help for that accountability, or have you found that that might just maybe antagonize the patient more?
It's a great question, and I haven't tried it, but at first blush, my reaction would be, if you set a goal for someone that means that if they don't achieve it, that they fail. And I think this concept of like how people feel when they fail might perpetuate not wanting to try. So I, generally speaking, just encourage people to do more, and I leave it a little bit vague, because that way you're not setting a threshold at which they might say like, well, that's impossible. I can't do this. That's my take on it. And it might be one of those things that probably it depends on the patient too. There might be some patients who do very well with a stated goal, who are, those people pleasers who say, if you tell me I have to do this, then I will do it. So maybe that's another way to individualize treatment recommendations. It's a very good question.
Thank you.
Thank you. And thank you for that excellent topic and discussion. I think I have a few more things that I can use the next time a patient says I am tired. Thanks for presenting to us, Dr. Gregg.
My pleasure. Thank you so much for having me.